Hi, everyone. This module is on vulnerable populations in healthcare. So first, we'll go through a bit of background on certain vulnerable populations, and then we'll delve into different groups that we're going to focus on. So African Americans, the LGBTQ community, disabled populations, prisoners, and then we'll conclude with legal and counseling considerations for each of these vulnerable populations in healthcare.
So, for generations, various populations have been subject to unequal access to healthcare services. Now, there have been a variety of laws set in place to protect these very populations. However, healthcare disparities still remain a long-standing and problematic issue that plagues not only the country itself, but the world as a whole. And this could be attributed to what are known as the social determinants, which include healthcare access and quality, education access and quality, socioeconomic status, social and community contexts, and the environment. Social determinants are primarily shaped by the disproportionate distribution of money, power, and resources, henceforth leading to healthcare disparities and a lack of access and quality services to these historically marginalized populations that we are going to talk about in the coming slides.
So the first group that we'll focus on is African American individuals. So it's helpful first to think of the history of racism in the United States. And to frame this, we'll talk about the civil rights movement from 1954 to 1968. During this period, there were demonstrations, protests, and engagements in which Black citizens and their allies fought to end discrimination and segregation. This movement culminated in the 1964 Act, which outlawed discrimination based on race, religion, sex, and ethnicity, outlawing segregation in schools, employment, and public accommodation as well. However, despite this act, society has continued to perpetuate racism, which has also included medical discrimination. So there are various ethical controversies that have led to longstanding medical mistrust, and some of these include the Tuskegee study and Henrietta Lacks. So beginning first with the Tuskegee study, this was a study conducted from 1932 to 1972, in which 600 African-American men aged 25 to 60 from Alabama were recruited due to a 35% infection rate of syphilis in their county. So these patients were administered ineffective medicines, and they were denied penicillin in an attempt to worsen their symptoms, and so that medical researchers could see the quote unquote natural progression of syphilis. So patients who grew weary and stopped attending appointments were even bribed by incentives and threatened. Another sort of ethical controversy that we think of involves Henrietta Lacks. So in 1951, a tissue sample from Henrietta Lacks was taken while she was seeking treatment for cervical cancer without her knowledge or her consent. It became the first successful cell line for culture in a laboratory setting, also known as HeLa cells, and are still used today. So neither Lacks or her family were compensated for her contribution to science. In fact, her family didn't know about her contribution until 25 years later. So both of these controversies have led, or just an example of some of the lasting effects of racism and medical discrimination that persist today. So in terms of medical mistrust, there may be a distrust to participate in medical research stemming from these instances with healthcare professionals, which is something we also may encounter as future genetic counselors. So it's helpful to acknowledge unequal power dynamics between providers and patients, even when providers themselves are minorities. So patients may not feel comfortable with GCs, genetic counselors who don't understand the long buried history of medical discrimination and abuse, and they may prefer to have someone who understands firsthand. So that's part of our mission as well, to increase access and awareness of genetic counseling. In terms of poverty and health literacy, those with low educational attainment and consequent low literacy and numeracy skills, including low health literacy, may find the language of consent documents difficult to comprehend, though a capacity for such an understanding is fundamental to ensuring ethical participation. So individuals with low levels of education and low socioeconomic status may lack access to basic healthcare or research settings for any research study trials. There's also underrepresentation in research. So marginalized and vulnerable populations are more likely to be structurally excluded from large pre-existing data sets and electronic health records. As a result, there is misdiagnosis or underdiagnosis of conditions that are more well-researched in Caucasian populations.
The LGBTQ community have historically been targets of discrimination, harassment, and injustice, including a struggle for equal access to healthcare. So one of the major issues is a lack of insurance coverage for these populations as well as their children. And even when LGBTQ community individuals are covered, there is a lack of equal access. So they're often denied services or treatments, such as in reproductive and infertility, and sex reassignment surgery or other treatments. There have also been a major debate over what's termed as the gay gene, as to whether sexual orientation is natural and or genetic. And this has been in debate since the 1990s and still is argued today. A matter of fact, in 2019, 23andMe tried to link genetics and sexual orientation through a survey in which they did a genome-wide association study of over 500,000 individuals. These studies are conducted by LGBTQ scientists themselves with good intention, but are part of a problematic tradition of research that isolates these very minority populations. Now, when we compare access to healthcare and health insurance to other populations, heterosexual adults are more likely to have health insurance coverage. LGBTQ individuals are more likely to delay or not seek medical care and not get the needed prescription medications that they might need because they lack that insurance coverage or they feel discriminated against. Several states also have state religious exemption laws that essentially allow providers to discriminate against LGBTQ individuals and deny services. A few of these states include North Dakota, South Dakota, Texas, Tennessee, Virginia, and 29 states failed to pass these laws to protect gay and transgender workers. There are also laws that are against discrimination that we'll talk about a little bit later during the legislation slide. But in terms of genetic counseling considerations, how do we address these health disparities? Well, there's advocacy, there's leadership, and there's community collaboration. And by doing all three of these, we can push in for legislation and push in for change that allow these populations to feel like they're being heard and they get that access that they deserve, just like everyone else.
Often there are multiple barriers that can make it extremely difficult or even impossible for people with disabilities to access healthcare. So I'm going to be discussing the 7 most common barriers. So attitudinal barriers are the most basic and they contribute to other barriers. So for example, stereotyping, stigma, prejudice, and discrimination. Within society, these attitudes may come from people's ideas related to disability. There are communication barriers experienced by people who have disabilities that affect hearing, speaking, reading, writing, and/or understanding, and who use different ways to communicate than people who do not have these disabilities. So for example, auditory health messages may be inaccessible to people with hearing impairments, including videos that don't include captioning. Physical barriers are structural obstacles in nature or man-made environments that prevent or block mobility or access. So an example is mammography equipment that requires a woman with a mobility impairment to stand. There are policy barriers and frequently related to a lack of awareness or enforcement of existing laws and regulations that require programs and activities to be accessible to people with disabilities. So, for example, denying qualified individuals with disabilities the opportunity to participate in or benefit from federally funded programs, services, or other benefits. There are programmatic barriers that limit the effective delivery of a public health or healthcare program for people with different types of impairments. So, for example, providers' attitudes, knowledge, and understanding of people with disabilities. There are transportation barriers, and these are due to a lack of adequate transportation that interferes with the person's ability to be independent and to function in society. An example is the lack of access to accessible or convenient transportation for people who are not able to drive because of vision or cognitive impairments. And often more than one barrier occurs at a time. And in terms of genetic counseling, it's highly important for genetic counselors to be aware of these barriers and to take the appropriate steps to try and mitigate these barriers.
Within the prisoner population, there's an overrepresentation of several groups that are already vulnerable in healthcare, and this population has a history of being experimented on while receiving inadequate services that hardly meet their basic human needs and rights, resulting in high death rates. Such examples include the public health and pharmaceutical studies that are listed on this slide. Since these studies, laws have been passed to protect these populations from being exploited for research. However, today some scientists are calling for reduced restrictions on studies involving prisoners, claiming that the stringent behaviors and daunting regulatory requirements are an overcorrection of historical practices and that those transgressions would never happen today. These regulations effectively, quote unquote, exclude prisoners from participating in scientific discovery. And these scientists try to make just three general arguments that I mentioned on this slide to support this claim. However, their arguments do have several flaws. For example, they seem to minimize the risk in view of the personal and public glory of scientific discovery. They also don't take into account the fact that prisoners may not actually be an ideal test population, given that they are disproportionately male, Black, have higher rates of drug use, illness, so on and so forth. And so these results may not be generalizable for the general population. Additionally, while research on prisoners' perspectives is scarce and it's plausible that these prisoners would like to see diversification of trial participants, this desire seems more aligned with the objectives of scientists and prisoners. And limited agency, while it is a problematic aspect of prison and it's difficult to address, the real answer would really lie in reducing the systemic oppression of the prison structure rather than bypassing the requirements for informed consent. It's unfortunate that we have to sacrifice potentially agenic behavior for strict adherence to the requirement of informed consent, but it's necessary to protect this vulnerable population, seeing that prisoners exist in such highly coercive environments where consent is basically not non-existent. So overall, allowing scientists to experiment on prisoners would give scientists free rein in areas where prisoners already have restricted choice. Given this history, there's several genetic counseling considerations to consider. For example, there's a lack of privacy and freedoms in these prisons, and oftentimes prisoners actually have to co-pay for correctional health care. And so all of this together leads to mistrust in healthcare and inadequate care for them. Additionally, there are pregnancy and postpartum needs that are not adequately recognized in prison systems. And given the recent overturn of Roe v. Wade, traveling out of state for abortion care becomes even further than next to impossible.
So on this slide, we're going to walk through various legislation that has come from some of the injustices that we've mentioned in these vulnerable populations. And so first, I'd like to mention the National Research Act, which was directly drafted as a result of the Tuskegee study, whereby the Office for Human Research Protections established guidelines to obtain informed consent for research on humans.
The Code of Federal Regulations, 45 CFR 46 subpart C, they generally limit studies involving prisoners to those that examine conditions causing incarceration or that specifically affect prisoners as a group, and generally prohibits studies that are meant to solely benefit the general US population because our prisoners may not be free to make a truly voluntary and uncoerced decision whether or not to participate as subjects in research. And so specifically, it only allows prisoners to be included as participants only when the research either is a study on criminal behavior, a study of prisons as institutional structures or prisoners as incarcerated persons, research on conditions particularly affecting prisoners as a class, research on practices which have the intent and reasonable probability of improving the health or well-being of the subject, and when epidemiological research has the sole purpose either to describe the prevalence of a disease or to study potential risk factor associations.
For the LGBTQ community, there are several laws that have been placed against discrimination based on affectional or sexual orientation, gender identity, or expression, passed by many across the country. 21 states have laws that prohibit discrimination based on sexual orientation, and 16 do so based on gender identity. There is an LGBTQ plus seniors bill of rights, which prohibits long-term care facilities and staff from discrimination and access to those services. Right.
Despite two federal laws that are in place, there are still barriers that prevent people with disabilities from accessing healthcare. The Americans with Disabilities Act of 1990 is one of them, and this law prohibits discrimination based on disability. The second law is Section 504 of the Rehabilitation Act of 1973 that explicitly states that healthcare settings must be accessible to patients with disabilities. Again, despite these two laws, there are still barriers that can make it difficult for individuals with disabilities to access healthcare. And these are our references listed here. All right, we hope that you've enjoyed this final module. We thank our program director, Monica Zach, and our professor, Heather Butts, for providing us the opportunity and guidance to create this module for you. And our slide template is from SlidesGo. For any questions or concerns, please don't hesitate to contact our program, and thank you so much for watching. You can check out our other modules for more discussions surrounding ethical considerations and genetic counseling.